all. Thanks so much for joining Making Healthcare Work for You, Different Perspectives and Empowering Solutions. I'm Stephanie Fields, joined by my co-host, Dr. Apoorv Gupta, and today we welcome Nilesh Bhandari, who's the founder of Advanced Health Academy. Thanks so much for being here.
Thank you so much.
We're happy to have you today talking about the research, the work you're doing really with diagnostic tests, blood tests, whether it's coming from a patient uploading the results to you or a provider or a healthcare practice. They're uploading these existing results that they have. And then your AI is taking these and you said you have a set of 2,700 rules that it's running them through to provide better context, making those connections. So tell us what exactly you're doing and why this is so important, how you got to this, because your background is technology, not healthcare.
Thank you, Stephanie. I've been fortunate. I've been surrounded by the healthcare profession all my life. And as a result, the one thing I've seen is the level of impact healthcare has not only on individual patients, but also on families and what that looks like, as well as providers. And seeing the level of physician burnout, the level of challenges for everyone in the healthcare staff side, it's been incredibly tough for me to watch for an area that matters the most for us. And as I looked at this, the other thing I recognize very simply is we have got an unprecedented level of diagnostics, new diagnostics coming out, new levels of treatment. Providers have, in my opinion, one of the hardest times of keeping on top of all of it to provide the best possible care to the patients that we all care so much about. But in that process, I think one of the most, let's call it retro, but one of the most, standard diagnostic tools out there are blood tests. We've been having them for more than 100 years, very often in a very similar way. And yet the process of reading, analyzing, diagnosing based on blood test results, we're losing some of the art of that. And partially it's because providers are stretched thin in terms of how much time and energy gets spent to dig into it and all the other information they need to go ascertain and gain over time as the medical knowledge is just mushrooming out. And so our goal here was, let's focus in on the standard blood tests that people get, CBC, a CMP, a lipid panel, a thyroid panel, an iron panel, many of the other common blood tests, call it heavy metals testing or some specialty cardiovascular markers, et cetera, and be able to diagnose this in a way for people to understand, what does this mean? And so we dig in and understand more broadly, not only every one of the different biomarkers, but also think about what the impact it has on the body. So we're taking the latest global medical research that we're updating on a regular basis. We are incorporating with that physiology and anatomy, things that every physician will say they learned in first year, a little bit in second year of med school, but very often have forgotten after practicing for 20 years or incorporate little elements of it. And we think about different pathologies and mechanisms of action to say, what are driving those different pathologies and what's the course of the disease progression, if you will. And in that process, be able to identify issues much earlier using blood tests as the mechanism by which to do so.
Yeah, it's so fascinating, Nilesh. I'm sitting here thinking you're reminding me of the things that I think I learned, or maybe I should have learned, and I was often wondered, why did I learn this? Because it's uncommonly used in clinical practice. So it's fascinating to me. When we first spoke, I was fascinated that you're working on this, because I'm like, well, what do you mean lab results? Don't we already know everything we need to know about lab results? It's kind of like the most basic of the basic. But it's fascinating that you found that there's so much value that's undiscovered within these lab tests. And frankly, the interactions across the labs has me fascinated, how you can help people, because we sometimes can evaluate lab results that are abnormal in isolation, but maybe not in combination. The way in which you've put together this kind of rules-based engine, to me, is really fascinating. I think maybe at this stage, it might be helpful for our audience to really kind of get a grasp of what you're talking about, to maybe give us a case example of a typical scenario, and
Mhm.
what is it that people, a physician and or a patient, might be able to learn using your tool and technology that they
Mhm.
wouldn't be able to learn otherwise?
So let me start off with the case, I guess. That's the easiest way. We've got an amazing medical advisory team, and I'll pull a case from an oncologist. Yeah, let me start there. Oncologist sees a 44-year-old female, history of colon cancer, status post, had a partial colectomy and radiation treatment, and basically 2 years post-treatment. So luckily, the radiological scans, CEA cancer markers show the cancer is in complete remission, thankfully. More recently, in January, patient had a blood test, CBC, CMP, lipid panel, thyroid panel. And basically, it showed a low white blood cell count and low lymphocytes. And the doctor assumed that the patient was still immunocompromised. And otherwise, the remaining biomarkers look to be in normal ranges, right? And I'm going to say normal with air quotes for a reason. The results were put through AHA, and the doctor realized that the patient had more issues, though they weren't surfacing, right? Number one, they had worsening anemia relative to prior labs, but still within, quote unquote, the normal ranges. They had low white blood cell count levels, but that was actually tied to spleen issues. And they had elevated protein, specifically albumin levels, which are indicative of stomach and small intestine issues, where basically the patient could not break down proteins. And then patient was dealing with low-level thyroid issues. And so the oncologist basically, looked at that, which had not really seen before, or had not thought through, because they were all within normal ranges. They were not within functionally optimal ranges, mind you, but within the green ranges that LabCorp, Quest, others would give. And I don't mean to single those out by any stretch, but the standard lab values. So the oncologist targeted the treatment a little bit differently. It basically was initially thinking about a generalized compromised immune system, based on what that means for the cancer treatment, but basically now refocused care differently, looking at digestive issues, which, by the way, for an oncologist is actually incredibly special, right? But trying to understand why the immune system was compromised more than just the cancer treatment, but what else was happening? Why were the stomach and spleen in particular areas of focus that came up through AHA? That was something that the oncologist was not thinking about prior at all. And so that organ health, sort of an organ function summary that AHA provides, made it a more robust picture for the provider. And basically understanding, because those organs were showing some levels of dysfunction, and also the summary report that AHA provided says, hey, here's possibly why that's happening and some of the indications of that. It helped basically the oncologist recognize that the patient was actually malnourished and slightly anemic. And that was explained the low white blood cell count and other issues. So shifted the approach, fair amount, right? Did not realize, the physician did not realize that the labs were abnormal, but instead we did. And in that process, by changing the original treatment plan, focus on nutrition, the patient started feeling better much faster. And that level of additional precision and broader context is what helps providers do that very quickly.
It's interesting because when you were talking before about the 7 billion tests per diagnostics run in the US every year, which is, an incredible amount relative to the hundreds of millions that there are living in the US.
Yeah.
So many of them, do come from specialties. Some come from primary care. So you said you have a pretty good mix, but we've talked before, and I think we talked, I don't remember if it was on camera or off camera, but about how people do lean on specialty providers. And then in a different interview, we were saying that sometimes specialty providers actually do kind of end up like primary care providers because people do seek that specialty care. So it's interesting that your product, whether intended or not, your analysis really has allowed this person to function in that role and help them in a different way that they may have never otherwise known. Because like you said, they're still in the green, which is why you said you focus, and I'm trying to find the exact wording that I wrote down. I think you said optimal ranges, not necessarily the normal ranges. And so why don't you tell us why that is so important? Because that seems like a really important distinction to change from what might be normal to what is optimal.
Normal ranges are based on medical consensus, medical community consensus, which makes a lot of sense. But the political process of building consensus takes a long time. It's a human process. We scour medical research from around the world. And what we have found on average is that when new research comes around, we're usually going to want to find a second source of that research. We will go do that. After that process, at least in the United States, very often they're by and large looking for a US source of that research. So there'll be a third research study then done in the United States. And then after that process comes out, let's say it all validates, hey, a range for a specific biomarker should change for these reasons. Then the process transpires to say, wait, how do we get there? Well, we talk about this as a threshold, and it's a binary. It's either worse or better, or vice versa. But in actuality, these are all spectrums. There's no binary good and bad. It is different levels of progression. And we've simplified to say good or bad, but we don't need to say good or bad. We can say, hey, this is great. This is a little bit stressed. This is a little bit problematic. This is a little bit dysfunctional. Like we can see shades of gray here. And that is where we're relying on the global research, number one. But number two, as we think about those biomarkers, how they get changed, we're thinking about those threshold values changing based on absolute thresholds. And that does take a long time because not only the research community buy into it, then the different physician communities have to buy into it, then the different physician associations have to buy into it. And only upon building consensus there does that change. But once again, what changes? Just the threshold level for a specific biomarker. As we think across that spectrum, people don't think about, instead of green and red, people don't think about yellow in the middle and what that looks like, or orange, or whatever the other color variations are, if you will. People also in the United States, by and large, don't think across multiple biomarkers at the same time. And what fuller picture that provides. Fortunately, there is research outside the United States that does do that. We have not incorporated that in the United States in the same way yet. Regardless, whether we do or not, we do know that the physiology, anatomy and physiology, basic, once again, first and second year of medical school, that information is there. And those things are, by and large, absolute truths. And so being able to lean on that to understand progression is incredibly important. And so we can find things earlier as a result, and we can think about what does that progression look like and why. After we've done all that, the next thing we've done, we've validated this. We've gone out to thousands and thousands of case studies and retrospective sort of patient case studies, and understood what has transpired and why and how, and we've kept fine-tuning as a result to make sure that this does work. Because once again, we want to make sure that this is tested and validated.
Nilesh, I'm really fascinated by your answer, and Stephanie's question actually makes me think of something that's connected. I suspect you're probably already thinking about it, but would love to hear more. Because when you think of normal range, then you think of optimal range. And yet what we're learning is in the age of personalized medicine, how that range really is very specific to an individual. So are you, through your system, now able to say, well, it's not just normal for the population or optimal for the population, but for me, Apurv Gupta, I'm an Indian male, middle-aged, and have a certain, a medical history. So what should normal or optimal be for me? Is that something your system is able to get to, kind of adjust what the normal optimal is for various ethnic categories or age categories?
So two answers to that. Number one is for both age, sex, gender, and for ethnicity, we do provide some level of changes, obviously, to what the normal, quote unquote, the optimal ranges should be. Let's not touch normal ranges right now. But then secondly, more importantly, the biomarkers are indicators, but the deeper analysis of what we do for the organ function, that tells us the answers in a much greater way, a much more precise way than even the specific biomarkers that contribute to that. And so whether we say, South Asian male or Northern European male of the same age range, and how those, let's say, cardiovascular markers and lipid panel markers, if you will, would normally be quite different for those based on what the research shows, which, by the way, has not been incorporated in the United States yet, but that's okay. The organ function differences come out glaringly, obviously. And so then I think, regardless of what the functionally optimal ranges are, the organ function that we see is really what drives value here. So yes, we've customized the optimal ranges based on demographics, if you will, and based on the latest research. But then secondly, the good news is the organ function that we're finding through the biomarker, through the blood test results, that's a perfect snapshot of what's happening inside the body in that instance. Once again, it's only in that instance. And the reason I bring that up is because they can vary from time to time, as they do, as they should. And so, and there are other very often compounding factors of why things may be out of range in that given moment. But that all being said, in that snapshot, we're able to see a lot of that function, organ function.
You were telling us that this is actually really valuable for value-based care practitioners, because being able to find these things allows them to bill at a higher level. So rather than billing for, not to say the word generic, but, for lack of a better word, generic type of visits, you're able to actually bill at higher levels for treating these specific things that are making a difference in the patient's lives. So tell us how that could really be transformative for value-based care in the future.
So I'll break it down into two different areas. So I think on the value-based care side, our providers have found that by finding issues earlier in their progression, and call it stage 2 disease progression, if you will, instead of stage 3 or stage 4, two things end up happening. Number one, interventions can happen earlier. Secondly, higher level awareness, even for the patient side, to make minor shifts in lifestyle, diet, behaviors, etc., can have a significant impact to slow that progression, if you will, if not to reverse it completely. That cost of doing that is much lower than the much more extensive interventions that are required later on in a progression. So from a value-based care side, we're saving providers and patients and the entire health system significant amounts. On the other side, on a fee-for-service model, on a reimbursement-based model, providers have really appreciated this because they're not only getting fuller context of health issues that are transpiring, but they're also able to bill for that appropriately. They're able to say, yep, there's a primary issue, but the secondary, tertiary, quaternary issues that we're also detecting, they can discuss to get a more robust picture. And two things end up happening. Very often they can code for higher because they're having a much more complex discussion with the patient, which helps the patient ultimately and prevents bigger interventions in the future. But then secondly, to the extent that the provider has capacity, they're able to get more patients come in and have a deeper discussion with those patients. The good news in all this, by and large, providers, and whether it be physicians or the nurses and all the staff in between, love the solution because it takes a really complex set of issues to understand the diagnostic of the blood test results and provides a lot of precision there, which the providers can then couple the clinical information they have and bring those two pieces together. So we're providing best of breed on one side where they have the most information on the clinical side, and they can bring it together much more easily.
Nilesh, this is fascinating what you're talking about, really eye-opening for me, because this is an area that I would have never even thought, needed any investigation, let alone all this innovation that you're unleashing. So tremendous. And it really warms my heart to know that the folks you're introducing it to, the physicians, are actually accepting it, because that's often the biggest hurdle and barrier. Is you could have the wonderful, most elegant solution, but ultimately getting people to use it is really challenging. But I think you've done a really good job of at least helping me understand that the doctors are appreciating it, they're loving it, so to speak. We didn't talk much during the course of this interview about the patients themselves. I think you had
Mhm.
said at the outset you wanted to focus a little bit more on providers. But as we're closing here, I wonder if you can share a little bit about how do the consumers themselves realize that they're getting this value? Do they understand more about what's going on for themselves? And are they able to therefore take earlier action themselves, or heed the advice of their physicians earlier as a result of the lab tests and the analysis that you're sharing?
Yeah, absolutely. Great question, Apurv. The answer is wholeheartedly yes. And how that plays out is very often today, patients can go and download the app directly through the App Store, iOS or Android. And in that process, they can upload their own blood test and get the same results, basically, and see what's for each biomarker, for the different organs, and basically an overarching summary that focuses in on what are the most significant organs, the most significant biomarkers to focus in on, and what to do about that. And so they're able to hear directly as well, why does this matter, where to focus in on, and how to make those improvements. The good news is for physicians who have such limited time with patients, it provides an easy way to be able to communicate with the patient to say, here's what the diagnostics are saying. Come in and see us. And when we're focused, providers love the fact that patients, if they've gone through that report, have usually done two things. Number one, they've better understood what's happening because we've done our best to explain this and basically call it high school English based on basic biology, but nothing beyond that. So we've simplified the language so people can understand it. But then secondly, we help people focus. So when people are then doctor Googling the next, like what's transpired here, what does this really mean? How do I get more information on it? They are focused, laser focused in on the areas that matter the most and not focused on some of the outlier results that come as part of a normal blood test result. And so it helps focus the conversation, the limited time that providers get with patients or patients get with providers, it helps focus in the conversation to the next level of, okay, understand this, what can we go do about this next? What does this mean? And the provider is excited to be able to transform the conversation from covering a whole host of areas to the focused area and going further within that. So all in all, the patients appreciate it and the providers appreciate it because it just helps focus this world of data out there and information to very specific areas that matter the most.
Somebody who has ranges that are in totally normal ranges and may not have any reason to consider this, is there still value to upload that and maybe have a way to track what their normal ranges are or their optimal ranges? And then of the people that you found, you said that you do have an incredible physician team that's looking over these things and making adjustments so that you are always up to date and have the best data that there is for these people. What are some of the things that you see when people come to you? Or do you hear reports through physicians that maybe they're very terrified that something's wrong because there's one particular thing out of range, or maybe they got it done at a specialist office? And then you find that it is something like the case study that you told us before, that this could be something that could be tweaked by nutrition and isn't something terrible that Google might have led them down to believe.
Great question, Stephanie. Let me answer with another case study, actually. I think that might be the easiest way to answer that. A female patient goes to see their PCP, basically for chronic fatigue. Thinking through the exact details here. She had seen a number of different, let's say internists and different specialists of different types. When I talk about chronic fatigue, she'd sleep 8 hours or more, but she still did not feel the sleep was restorative at all. She was gaining weight. She exercised regularly, but despite that, she was still gaining weight. And she had just started developing developed chronic acne. And she was trying to address that as well. I mean, so she, topical drugs, that didn't work, antibiotics, even trials of elimination diet to get there. No real solution. And so this PCP had ordered blood work basically to sort of see if they can find a differential diagnosis. But when it came back, there was nothing striking that came up. Everything looked in range. And so the PCP was a little bit stumped about what to go do. The PCP put the lab through AHA, and basically we pinpointed specific biomarkers that were suboptimal, but within the lab's normal ranges. So in that process, it basically flagged that the thyroid, in terms of the organs, the thyroid, the stomach, the lungs were partially compromised. And, the doctor looked at it and said, well, wait a minute, like stomach, thyroid, lungs, like those are three disparate systems. Like, how are they tied together? Like, how does that come to be? And so basically AHA pinpointed that, and I say AHA, the rules engine basically pinpointed that the key issue was that the woman had anemia at the end of the day. But that was not obvious, right? Because hemoglobin levels, hematocrit levels were all within normal ranges. So it was not obvious that there was any level of anemia. The PCP did end up doing an iron panel, and we found, she found that the ferritin level was borderline low, still within normal ranges. And the CBC was within normal ranges, right? So the physician never thought about anemia. But because the AHA was focused in on basically thyroid, stomach, and lungs, and really the stomach, which you think about, AHA figured out the stomach was not able to break down the iron from different animal sources. And basically, and there was insufficient production of RBCs. And so the doctor discovered patient was eating lots of red meat, right? Mostly for iron, ironically. So the doctor was able to convince the patient, change the diet, try this, right? To be more whole food, plant-based, iron-rich foods, and cut out a lot of the animal proteins. And so 2 months transpire, physician sees the patient again. Patient is literally on cloud 9. Basically less bloating, less digestive issues, stuff that she's been dealing with for most of her life. Her sleep felt much more restorative. The very, chronic fatigue issue were dissipating as a result. She had a lot more energy, to the point where she was actually even drinking a lot less coffee. She didn't feel like she needed it anymore. And without even focusing on it, she had lost about 5 or 6 pounds in 2 months. And on top of all that, her skin started clearing up a little bit. Basically, the inflammatory acne were tied to her diet. We were able to do that. A month after that, so 3 months after the first set of labs, PCP orders another, blood panel, another blood test, right? And see how did things look relative to the initial. And AHA comes back and shows that the iron levels had normalized, the other abnormalities had improved. And so AHA is able to go to that level of precision to find things even when they are normal, and yet they feel like medical mystery sometimes. It's able to find some of these different issues and pull that out. So I think there's a lot of value to this that we're hoping that, can help providers in particular and patients to help streamline their process and have richer information and find some of those deeper insights much faster. So that's our role.
Maybe not have to end up in a scary situation worried about that.
That's the goal, right? Absolutely. We talk about the cost of medicine, and we talk about the financial cost, but the human cost is also significantly high. And if we can minimize both those or reduce both those, what better impact can we have on the world? I don't know anyone who's not gone to medicine without thinking about the human impact of medicine and how we can help others. And this is the goal to do that.
I think what you're saying is any patient, they don't necessarily have to have a primary care physician or a specialist that's using AHA. Anyone can download this tool and put in their labs and get this diagnostic, right?
That is correct. So, for everyone out there, there's if you go to your Android or iOS app store and look up Advanced Health Academy, you'll find our app. Feel free to download it. You can upload your blood test results. You can take pictures of them. We will analyze it, and we will provide the same answers we give to providers. And for providers, we're happy to integrate with whatever your EHR system is and integrate this entire process so you can run this through your normal process and have this additional tool to take a lot of the diagnostic burdens off your plate and put those elements together with your clinical information, and you can combine those two elements together on your own.
If a patient uses your portal and then has a question about them, is there someone they can contact, or do they have to then contact their doctor about it?
So by and large, we ask people to discuss this with their physicians, because the physicians have the context there to be able to explain clinically what's happening in addition to the diagnostics. But if there are questions, we've got a support line, we've got support emails, et cetera, all built in through the app. Feel free to reach out to us. We will do our best to answer what we can, as within context.
It's remarkable. And when you were talking just as that final case study, I kept thinking there's an episode of Golden Girls where Dorothy has chronic fatigue and she keeps going to doctors and no one can figure it out. And I thought if they had AHA, Dorothy could have figured this out much more expeditiously and gone back onto her normal life. But thank you so much for being here.
Well, thank you so much. Really appreciate it. And I hope this can be a big asset and a big help to everyone out there.
Absolutely. It's so fascinating. Thank you, Nilesh.
Thank you.
And thank you all for watching. We'll talk to you soon. Bye-bye.